Well, it's a pleasure to be here, and I first just like to thank Leslie. It started with the visit for me down here about a year ago, and then Dr. Jerry Fishback met later and had a chance to talk, and so I'm very, very glad to return to be able to talk about some of my work. So the Department of Biostatistics is housed in the Melman School of Public Health at Columbia. So I just wanted to start out by telling a little bit about the school and the department, some of the areas of strength and future directions of the department, and then I'll venture into my talk. So the department, the Melman School has 6 departments. Biostatistics, of course, is the department that I lead, but we also have expertise in environmental health sciences, epidemiology, health policy and management, epidemiology, I mentioned that, social medical sciences, and then population and family health. And I mentioned this as I read the sort of the lecture series, Frontiers of Data Science, and I thought about the school. I feel like we're all sort of partners in data science, and really it's the connection of data science and health, and we approach these things in complementary ways, and the same goes for the school-wide centers, the Robert Butler Columbia Aging Center, Center for Infection and Immunity, and then what we refer to as ICAP, International Center for AIDS Care and Treatment Programs. The Department of Biostatistics is one of the oldest departments in the country. We're about the 3rd oldest, or we're exactly the 3rd oldest department in the country, and the evolution of stat departments across the country, most stat departments are older than biostat, and either war or agriculture contributed to the launching or growth of many of the stat departments, but we were founded in 1940, I think owing to the fact that the Melman School is one of the early schools of public health. And we have faculty working in a number of areas, but I'll talk about just areas around that are focused on big data areas. And when I say big data, some of my faculty feel like it's business as usual because they've always worked on these kinds of data sets. But really, what we're capturing here are the increasingly complex types of data. So, and if we think of a well-structured, well-behaved data set, and we just grow the number of records, in some ways that's not so tough to handle. But in many areas, and I'll give some examples, it's the increasing complexity that makes things interesting. And here are a few examples here. Data from emerging technologies like smartphone apps or wearable devices. I usually wear a Fitbit, and the data that we collect, sort of around the clock, day after day, that we're no longer thinking about the data in its simplest form necessarily as a single value scalar. It's a curve or much more sort of enriched data object that we're thinking about. Electronic health records, brain imaging, and you'll hear more from me in brain imaging, and then genetics and genomics. And lastly, I'll list kinematics. I'll give an example of that as well. So this isn't an exhaustive list, but we do have expertise across the faculty in these big data areas. Some examples, if I were to ask my faculty areas of expertise, some would define it by methodological area, some would define it by area of application, some would define it by data source, but this gives some of the areas I think we're really advancing science on, and we're really making an impact. One, across a range of areas that I've termed here as brain health because they capture neurological disorders, aging, and psychiatric disorders, but then cancer, surgery, environmental risk factors, and a number of areas like that where, in each one of these areas we're confronted with data that are collected, in a way that brings complexities to analyses that our faculty get involved in terms of leading the charge. So to clarify a few more examples, and then I'll dive in. These are examples not of my own work, but by work of faculty. we'll call it, there's no pointer. This first panel here is just an example of a work. It also uses brain imaging, but slightly different than how I'll use in my talk, where a faculty member, Yuanzhou Wang, is looking to model progression toward Huntington's disease. And so it's a sort of a failure time model that is adapted from the traditional area of survival analysis, but now it has to be adapted to accommodate massive amounts of data. This is a exome sequencing study from, or data by a faculty member, Juliana Ionita Laza, and there she found a susceptibility gene that is, which is pictured here in red, FAN1, and you see there's sort of a network structure, and so this gene was shown to be associated with schizophrenia and autism. But in addition to looking at just sort of that individual gene, how does it interact with a number of other genes? And there were 27 identified there. And then lastly, hopefully this is big enough. And this again gets to the point of more the complexity than the size. So here are, these images go together. And I'll tell you what the task is. You start with a pin at the center, and one of these circles around the periphery will light up, and you're to draw a line from the center to the illuminated circle and then return back to the center, okay? If I show you that and I tell you that one of those pictures is from a patient who suffered a stroke and one is from a healthy control, I think your eyes will be able to immediately determine which one is from a stroke patient. But how do we, the question becomes, how do we think about capturing this this data in a way where we can actually model it, not only to determine what our eyes can see, but then even thinking about an intervention to assess improvement in this. So these are kinematics or motion data that a faculty member, Jeff Goldsmith, is working on. So just by way of example, I wanted to give you a little bit of information about the type of work that my faculty are involved in. All right. And now I'll talk a little bit more about the project that I'm leading, that we're just finishing an exciting discovery phase of the project and setting up our plans to do the next phase of it, which I'm very, very much looking forward to. Before I get started, I always like to start with, in fact, I like to start and end with my collaborators, just to make sure that I acknowledge the people who did all of the hard work. But the idea behind the project, it really fits into a program launched by NINDS called the Parkinson's Disease Biomarker Program. And so the work that I'll talk about now is one of the original 8 grants funded under this initiative by NINDS. And just as the name suggests, it's sort of a concerted effort to try to find biomarkers, and in particular, I think early stage biomarkers for Parkinson's disease. When I talk about biomarker, somewhat of a definition, or at least perhaps a qualification, that I'm thinking of it as defined here: a characteristic that's objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention. So that's a rather general. If you look up many definitions of biomarker, you'll see definitions that sort of vary in scale. So some may think of it only as a molecular level marker, but we're thinking about it more broadly. Could even be behavioral. We'll focus on the neuroimaging phenotypes, but again, it's kind of a general definition. And as of yet, there are no proven biomarkers for Parkinson's disease. Parkinson's doesn't need much of an introduction. Most of you are familiar, may even know people with Parkinson's disease, but it is certainly a devastating neurodegenerative disease that affects over 1 million people in the U.S. and estimated 7 to 10 million worldwide. The hallmark the hallmark symptoms are a set of motor symptoms that involve tremor, rigidity, bradykinesia, which is slowness of movement, and impaired balance and coordination. And then there are a host of non-motor symptoms. You can have constipation, disruptions to smell. Sometimes you notice a change in orthostatic blood pressure, a number of things like that. There's, as of yet, no diagnostic test to validate it, and that a definitive diagnosis is essentially made post-mortem. And then in terms of drug treatments, there are drugs available, but all of the drugs right now are really to try to mitigate the symptoms, but none halt the progression. Okay. So I love this board. It's large enough where you may be able to see the labels on the axes. So on the left we have neuron function on the y-axis, and the x-axis we have time. And there's a faint gray line here that shows it sort of characterizes a decline in neuron function over time. Okay. And then this vertical line marks the onset of symptoms. There's usually a lag between the onset of symptoms and a diagnosis for Parkinson's disease. So this vertical line represents the time at which a diagnosis is made, and what we see is that there's already substantial decline in neuron function, and so this window really is the window that we have to take advantage of as sort of the optimal time for neuroprotective treatment. The problem is, we have to find markers that manifest during this early phase. So I think that really kind of captures the spirit again of the Parkinson's disease biomarker program. There are other initiatives targeting a similar thing. Our work as a field, in many cases, we're still kind of operating on the boundary here. Okay. And there have been sort of a phased pathologic process that about Parkinson's disease and how it starts in like the locus coeruleus and substantia nigra and sort of gradually goes up to the cortex. But generally speaking, Parkinson's disease is characterized by the loss of dopamine producing neurons, and these neurons, at the time of a diagnosis, they may be 50% depleted already. So, if that has been in place for a long time, that probably marks this rapid decline, even by the time symptoms start, much less a diagnosis that we see characterized in that picture. All right, so we're gonna take a neuroimaging view to try to identify some potential markers for Parkinson's disease. And right now, they won't be guaranteed to be early phase markers, but the hope is by identifying sort of a broad set of robust markers that will follow them, sort of in future research to track back in time to see how early they manifest. So we're going to use a small development data set of 47 subjects, with 29 being PD patients, 18 controls. We have imaging data, and I'll go through the different types of imaging data that we have, along with demographics and clinical measures. Now, imaging has been used for Parkinson's disease research in the past. In the past, though, people have tended to use a particular modality, a particular characteristic, and really hone in on that. And what this research is going to do is really try to expand that view by looking more broadly kind of at various functional and structural level properties. And so I'll walk through now the different types of modalities that we use that we'll eventually draw from. So they're all, when I say multiple modality, they're reflecting different properties of function and structure. They're not from different machines, so they're not necessarily multimodal scans from PET and MR and EEG. They're all based on an MR machine, okay? The first that we will use is just a basic MRI. We refer to it as T1, and it reveals kind of underlying brain anatomy that distinguishes gray matter, white matter, cerebrospinal fluid, and we can quantify certain properties like the density or volume of the tissue. And these things have been, the representations that I'll talk about have been indicated for other neurological or psychiatric disorders as well. FMRI, I've drawn a bit of a picture to try to explain FMRI. Many of you are already familiar with it, but for those of you who are not, I wanted to just try to give you a sense of the data. So people come in and lie in a scanner, and we acquire images that capture more or less the whole brain, and then we'll capture a sequence of those roughly split by, say, 2 to 3 seconds. And in each image, so this would denote the first image, we'd scan down through time t, whatever that is. Usually a scanning session may last 15 minutes or so, so we get a kind of rich collection of images. And the way I like to describe one image is a Rubik's Cube, if you're familiar with the toy. And you can think of a finely partitioned Rubik's Cube, so it's just like a regular lattice, and so each volume element will contain a measure of brain function at that particular location. Okay. And as you'll see in a moment, if we take one image and just string it out into a long vector and include it in this column, take the second image, do the same, take the third image all the way up through time t, then essentially what we have is cutting across a particular row. That will give us one location in that volume element. So a particular brain voxel, which is on the order of 2 cubic millimeters or so, and this would depict the evolution of brain activity throughout the scanning session. So it's a time series for those of you who think in terms of the data. So we essentially have a collection of 300,000 or so time series. And from a modeling, I won't talk much about this, but in part what got me interested in modeling these types of data in the beginning was a lot of the dependent structure. There's clear temporal dependence here, so the height of activity at one time point at a particular voxel is partly related to the activity at nearby time points, and then spatially, there are a lot of dependencies with the brain. It's a bit difficult because let's say we're monitoring air pollution from a smokestack, and we have monitors. Then what the measurement levels at, say, 2 monitoring stations are likely to be highly correlated, and if we think about all of them together, perhaps the degree of correlation may depend on the distance between the monitors. But in the brain, that's not true. You can have things that are very far apart. We have this rich, amazing neuroanatomic structure where things are hardwired. So that's part of the difficulty modeling there. Okay. So we have just the basic T1, then we have fMRI. Now I'll talk about diffusion imaging, and that gives us structural information as well, but a different kind of structural information. So that gives us structural information on the white matter in the brain, the axonal fibers, and essentially the way it works, water molecules will diffuse more easily along the direction of fibrous tissue than it will against. And if there's no favored direction, then we would think about representing that as a sphere. Here we see kind of these elongated spheres showing that there's fibrous tissue. So a lot of times I'll look at carpet or other things like that, or celery sticks. You know, if you put water along a celery stick, it's going to often, it would have a higher tendency to diffuse in one direction rather than the other. And so that's essentially the way the MR machine can be used to determine directions of fiber tissue in the brain in the white matter. There are some complications, as depicted here, of crossing fibers. So we see, you know, fibrous tissue in that direction. Perhaps there's difficulty sorting out right there, sort of the major direction. So that's the information that we can get from diffusion imaging, and then we can apply algorithms to actually track that and reconstruct major white matter tracks, you know, going voxel to voxel, determining likely pathways. Okay, and this is a sort of a preview for the remainder of the talk. Again, the basic idea here is rather than look, you know, at a particular modality and to see if we can find links with Parkinson's disease, to see if there's any benefit in combining the modalities. And they all have relative benefits. I'll elaborate a little bit more on that later. There were two phases to this project. One, we actually did a hypothesis-driven approach, or are doing. That's great out here because I won't talk about it, but there we're looking specifically at the locus coeruleus and the substantia nigra. You have to scan differently. The locus coeruleus itself is only 7 millimeters or so long, so a couple of voxels, so you have to really hone in on those. This is, you know, the work I'll talk here is more the sort of the broad exploratory view to say, you know, what are some of these neural alterations that we can identify that are linked to disease. All right, so I've explained the modalities. We now have to draw information from it. I've hinted to at least one measure that we'll draw. From the T1s, we can compute things like cortical thickness. What's shown here, this was from a model that we developed prior to doing this work, but this shows in red areas where the cortical thickness is higher in PD than in controls, and then in purple areas where just the other way around, the cortical thickness in controls is larger than in PD. But we can have voxel-based measures like that, and then include those in our analysis. And this is a basic T1, and in fact, in the analysis, the gray matter density is very much related to that cortical thickness, but they are distinct measures, and we're actually going to use VBM in the results that I'll discuss later. This is the fractional anisotropy that I kind of described in terms of the diffusion imaging, and then the tractography results that we'll have there. So between every pair of regions, I'll explain that later, we'll have a measure of the probability that those two are connected by a white matter fiber track. And then at every voxel course into a region, we'll have a measure of just FA, which tells the preferred direction. It's essentially, we have a tensor matrix, and we compute the eigenvalues of those matrix, and from the eigenvalues we can determine the preferred direction. And then the functional MRI, all right, functional MRI can be done while administering a task, or it can be done during resting state, where subjects are just left to think for themselves in the scanner. And in our case, they were resting state scans, and so the localized information from a resting state scan is a little bit less clear. What we do is we capture the sort of the power concentrated at low frequencies. And so there's a measure of fractional amplitude of low frequency fluctuations that we calculate at every voxel. And then a merging area of research involves resting state functional connectivity, and that's just, how do the time series, the evolution of brain activity in different locations correlate with one another from different regions. And so this doesn't show the actual patterns of connectivity, but just sort of all of the different potential links. Okay, so we've covered the modalities and then the sort of the data representations pulled from it. I'll talk a little bit more about it, but if it's not evident already, we have a bit of a dimensionality crisis here, and we'll have to manage it. There are roughly 300,000 brain voxels at one time, and that's after we do smart things like throw things out that are in the frame that fall outside of the brain tissue, and so. The localized measures, even themselves, 300,000 across multiple modalities, could be, a bit difficult to deal with. But when we think about the pairwise measures, we have over 45 billion voxel pairs, right? So that's just too many data to want to think about modeling in a reasonable way based on the amount of data that we have. So what we're going to do is we're going to summarize the data using a standard parcellation referred to as AAL90. For the functional data, some of those regions are very big, and we weren't so comfortable that the, say, functional characteristics are uniform within a large region, and so for the functional data, we're actually going to subdivide them into 290. Okay, we're not going to do that with the white matter, largely because we'll have many sort of empty or zero locations. All right. So in summary, we'll compute the regions, and then we'll compute regional summaries. So the FA is that localized DTI based measure that will have that calculated within each region. The voxel-based morphometry is again drawn from a T1 and talks about kind of the density of the tissue at a particular region now, summarized over the region, and then the same for FALFF from fMRI. And then the pairwise measures will have functional connectivity and then structural connectivity. This looks more dense than that because, again, we're using just the 90 regions for structural connectivity. All right, so now, so that essentially describes the starting point of the modeling process. And so for modeling, and the work that I'm going to talk about today is sort of one piece of it where we'll use a fairly common penalized likelihood approach, where this is a log likelihood function, and this is a penalty term here. The penalty term, for those of you who, some of you may recognize it, the penalty term combines two pieces. One is essentially analogous to ridge regression. The other is analogous to the lasso, and each, the proportion of either is determined by the weight alpha. So lambda and alpha are both tuning parameters. If alpha is equal to 1, we're applying a lasso penalty. If alpha is equal to 0, we're at ridge regression. And so they have trade-offs. One of the reasons we don't just do lasso here is that we have possibly highly correlated features, and so that is troublesome for lasso. And then for elastic net, for ridge regression, it doesn't do any variable selection. And ultimately, then that'll be a key piece as I talk later, because ultimately we want to push parsimony. So this is the framework that we're going to use, logistic likelihood function. The benefits of what we're going to do, so we're going to pool, again, predictive strengths across multiple data modalities. We're going to perform variable selection and shrinkage. It's well suited for high dimensional data. the process works essentially by doing a testing or training and testing, cross-validation process. And then lastly, we're going to adapt the standard implementation of these to encourage reproducibility and robustness. And then the third thing that I don't have written there that I just alluded to is parsimony, and I'll make that clear in just a moment. All right, so we did a lot to try to manage the volume of data that we have without coarsening too much, because we don't want to throw away a lot of the rich information. But we still have over 46,000 features or pieces of information that we're drawing from the multiple brain modalities. Okay? So we began by doing a fairly aggressive univariate independent screening. And to pick up on the point of reproducibility, when one screens, on a different sample, maybe you come away with a completely different set of variables. And so we actually performed bootstrapping and selected our variables post-screening based on results of the bootstrap samples. Okay, so what that will tell us is if we collect another data set and perform the screening process, we feel like the things that we found will be more likely to emerge as opposed to if they were selected just based on these data alone. All right, so if one just takes and runs a standard elastic net to those 271 features, you can apply, you can translate that into a prediction by identifying the predicted probability for each subject. And what we get is we get very, very high accuracy. This is a good place to explain another thing that we do. Well, before I do that, as not to impede the point. So we get very high accuracy. So this is a receiver operating characteristic curve. Sensitivity is pictured on the y-axis, 1 minus specificity. So we want to be in that top left corner. And if you look at the black trace there, that's really, 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 really high accuracy with an area under the curve of 0.989. Wow, that's great. From a variable selection, we use all 271 variables to do that. So what that says is if you give me these 271 pieces of information, we can achieve high accuracy. Okay. This is where we have to distinguish, our objectives. At the end, we're at the discovery phase, but ultimately we want to learn something about disease mechanisms. Where do we begin with 271 features, right? So what we want to do in this first phase is to try to achieve good accuracy, but also, to simplify the problem a bit, where we're teasing out what are the important drivers, and then those will be candidates for the next phase of the research as we're trying to dig a little bit deeper into them. And so there's this accuracy versus, I wrote here, neurobiological meaning trade-off, and that's really what prompted us to pursue the next phase of steps here. So the one additional point about, again, trying to encourage reproducibility and robustness. If one does cross-validation, essentially you take your sample, you split it into two. In the easiest case, you may split them into more than two groups, but for sake of explanation here, we'll split them into two groups. We train on one, test on the other, and then calculate our performance. We can flip them and before quantifying our final testing results. How you split can matter. That you will see variability based on how you split. And one never knows if you happen to get the most favorable or the least favorable of the number of potential splits. And so we repeated the process here also a couple, like 200 times. And so that's why you see these colored curves here. So each one of those traces sort of maps what we would get from one particular cross-validation split. And then the black shows on average across the 200. So this is lambda, that one of the parameters in the elastic net. This is alpha. I mentioned alpha at 1 puts us at lasso. Alpha at 0 puts us at ridge regression. This point A happens to be where we land when you just apply elastic net that keeps all of the variables and gives us wonderful prediction, but at a place where it doesn't, we don't stand to learn very much. So how we approach the problem is we created a bounded search region in the tuning parameter space. The colors here represent area under the curve, with 1 being at the top, 0.5 being blue. If we're worse than 0.5, we would hopefully flip our guesses and do better. And then each one of the points in this operating plane, again, represents an average over those 200 that I mentioned. And so what we do first is we draw this white boundary, and what we say, so that boundary is determined by or set with P equal less than 75, less than or equal to 75. That means we don't want to keep more than 75 features, okay? And we set that sort of arbitrarily, and then we achieve good accuracy. We're willing to give some of it up, but we don't want to do terribly in search of parsimony. And so this black trace corresponds to AUC being greater than or equal to 0.9. Okay, and so at each point you'll keep possibly a different set of variables, have different performance. And so what we ultimately aim to do is try to identify and extract features that, again, are consistent across all of those operating points. As you sense in my talk, we're less interested in claiming just the bottom line prediction number, because this is still just discovery phase, but really, are we finding things that will show up again? And so we want to try to make sure that they're robust against a lot of these sources of variation or choices of tuning parameters. So, and this point this plot on the right happens to just map this point E, and what's shown here, this is the magnitude of the regression coefficient for a particular brain feature, and then this is the number of times over the 200 that it was kept. It's color coded, so green are functional connectivity, red is VBM, we have a couple of those, and purple is structural connectivity. And the other modalities, you'll see them scattered throughout here. But for the things that had the highest coefficients, the strongest drivers, the strongest predictors, those were the 3 modalities. Okay. Okay. And so mapping or tracking the variables kept. Or actually not the variables kept, but the variables that fell above that reference line. So those were the top, the coefficients that fell into the top 10 percentile of the predictive strength. At each point in that bounded search space, this column essentially gives the percentage of times that they fell into that category. And so you see many of the features here that we've identified were consistently strong across all of the different points considered in the search region. And so all of them are very high. Many are 100. The others are, I guess the lowest looks like 91% at the top. Okay, so those are 23 features that we know work well. They work well in a number of settings, sort of robust to a number of things, including sampling variability and tuning parameters. It doesn't take all of these variables to achieve accurate prediction. Again, we're not just trying to achieve accurate prediction here, but to get that candidate list to go to the next phase of our research. And in fact, we can achieve almost perfect prediction with subsets of as few as 3 variables from that expanded list. And this shows a few of them here, or 3 models that achieve perfect prediction with just 3 variables. And so we see functional connectivity there, and voxel-based morphometry show up here. It's interesting to look at the regions. The thalamus shows up, and then some other limbic system regions. So we have the hippocampus, the amygdala. The orbital frontal cortex was interesting that showed up, and then the cingulate gyrus, the posterior cingulate, actually anterior and posterior cingulate. Okay, and then what we've done is we've plotted just sort of the effects, right? So for each one of those, what's the alteration that we were able to detect for patients with Parkinson's disease? And you see they vary. And I'm not going to go through these one by one, but there are some things that I note here, like the right precuneus, that's the green one, the structural connectivity. So that's not statistically significant. Those are error bars individually. It's not, although it still contributes significantly to prediction. But nonetheless, we see it's in a sort of a negative direction, and then correspondingly, this precuneus exhibits this precuneus functional connectivity with this occipital lobe region, and then with the cuneus, those also show decreased functional connectivity in patients with Parkinson's disease relative to the controls. 3 amygdala, sort of hyperconnectivity, and then this thalamus are just a few that we noted. Okay, so in scanning patients with Parkinson's disease, there's a important thing that we have to consider just logistically. We, meaning the clinician, has to consider logistically, and that's whether to scan on meds or off meds. It's a huge issue because even skipping a morning dose or the previous night's dose can cause flaring of symptoms, and that can be very, very unpleasant for the patient, and also in some cases could affect the scans. But at the same time, if you scan on meds, what are you finding, right? And so people have chosen, and people feel adamantly one way or the other about which way is the right way. In some cases, if the data that I just showed were scanned on normal course of medications, and so we didn't really have many artifacts with subject movement and things like that. But it does raise this question: for the functional contributors that we saw, what are we seeing? Is that characteristic of Parkinson's disease? Is that characteristic of the medication, right? So that's something that we're planning to sort out as well. And so again, in this sort of initial discovery phase, we repeated exactly the process that I just mentioned to you, using only the structural scans, the VBM and the structural connectivity and the FA. And so what we found is that we still can identify 7 features that give very consistent performance across all of the sort of the repeated samples and across all of the combinations in the bounded feature space that I talked about and described in detail earlier. And so what we know, and we did this separately because at the next phase we'll actually analyze data where subjects are off meds, and we think that the structural features should be less sensitive. That what I just described about the functional, while that's obvious that there could be a clear impact there, the structural scans, we would think structural connectivity would not necessarily be affected so much by medication. All right, and then this is the ROC curve associated again with just that smaller list of structural only. So we can still achieve very high accuracy just with those structural variables. Okay, so my takeaway, I'm excited about that discovery phase because I think there's information there that warrants our next step and sort of deeper dive into, first validating those measures, making sure they're truly robust in independent samples. We think we've taken all of the steps that we can take to sort of encourage that here with the available data. And then eventually, again, begin to explore, what are the underlying mechanisms? How do those regions interact with one another? What do we already know about those regions? So the next phase of our research, we're already in the process of kind of planning our validation study. We'll look at, I mentioned the robustness to treatment, and then also PD progression is an important thing that we'll target in the next phase as well. There's a scanning modality I didn't mention so much here that's involved in the diagnostic process. It's thought to perhaps do a better job detecting Parkinson's disease than monitoring PD progression. And in fact, because of the tremendous dopamine loss prior even to diagnosis. So from a monitoring standpoint, it's a little bit harder to achieve. So that's something that we'll target at our next phase. And then what we've done is we've amassed 3 independent data sets, and I'll talk a little bit about those. And so we're actually planning out a kind of a Bayesian sequential analysis phase to think about really our data kind of as a collection here rather than just one by one an independent validation. We will do that, but to think about kind of developing potential markers in an ensemble of training data sets and testing data sets. All right, so this is the next phase of the research. We have data. We've partnered with investigators at the University of Florida, David Valancourt, and then we have data from PPMI, Parkinson's Progression Markers Initiative. And so we've collected data from 226 individuals at baseline. 2 of the data sets are longitudinal, having a second scan a year later, again allowing us to look at progression markers. The multiple modalities is the key piece again, and we'll look at the T1 plus DTI, that will be akin to the structural only, and then the T1 plus DTI plus the resting state. For the resting state, PPMI has fewer, so we may just limit our attention to the 80 additional scans that we'll have from the University of Florida that have all of those, but we'll look at the available data. Very good point. So the University of Florida data are off meds. Okay. The PPMI data are never treated. So that's a great point. You reminded me to comment on it. So there's what we're doing is we're actually more than just mere validation on a data set that's sort of exactly identical to the one we had previously, just an independent sample. What we're really going to do is try to better characterize the property of the things that we found here and under these different settings, and ultimately I think that will help to inform how likely or how useful they'll be as eventual markers. But I'm very, very, very encouraged because there's clear discriminatory information that we've identified in the data that we have at hand. All right, so in summary, the multimodal imaging data do contain discriminatory information. We've sliced the data a million ways, and I can confidently say usually when I get ROC curves that show the accuracy that we saw from the original slide, I get nervous. Prediction is hard in real life, but there's clear discriminatory information there. The penalized regression framework works well. We actually preceded it, the part that I didn't talk about. We developed a whole modeling framework that has some advantages that we'll use in different situations. And I think what we've accomplished is in some ways astonishing that we start with so many potential features, and then we're able to select out just a few that show remarkable accuracy. There is the delicate balance between parsimony, just trying to keep a relative few number of things that emerge. What's the magic number? We don't know. We just don't feel it should be 200 or 300 or all of them for that matter. So it's not just clear or black box prediction that's important here, but really ultimately the goal of learning at the end. And then, empirical validation in quotes now, given the previous explanation. And then lastly, again, to further examine the brain structures involved with the focus of those putatively affected in early stage PD. So, as I think more generally just about opportunities, I think that we're on the brink of major breakthroughs as it relates to neurological disorders, psychiatric disorders. When I say we, I'm actually meaning the scientific community here. And being a part of the Parkinson's Disease Biomarker program, there's a lot of exciting work. And, what will make those breakthroughs possible? What will make the progress? What has made the progress to date possible? A few things come to mind. One, advances in technology have played a clear role. And then moving forward, I talked about moving from a single modality to multiple modalities, and I think in the future we'll do even a better job. We've done it in a limited way, but we'll need to do a better job as a community, kind of aggregating disparate data sources. And so rather than just taking a sort of a genetics or genomics view, or looking for markers in blood or serum, that we take all of those and combine with imaging and sort of take a more holistic view. And then lastly, and this is, I think, apparent in many fields, but certainly true here, the advanced analytic techniques really will help us to realize the opportunities at hand. I'm seeing zeros in the back, so I'd like to finish by thanking my collaborators again, and thank you for your attention.